it kind of chose me in that I was diagnosed with osteoporosis when I was 28. So I'm just about to turn 50 now. So we're talking, it's been a while. And it came as a really big shock. And I was already an exercise professional at the time. And even with all the resources that I had at my disposal, it was still a shock. And it was still overwhelming and scary. I have a very clear understanding of what many people are going through when they're surprised and they're dismayed at a diagnosis of osteoporosis. And so overcoming that is a big deal. It's something that is a process, but is very doable.
I'm Jessica Vallant. I'm a physical therapist, women's health expert, and Pilates teacher, and my goal is to help all women feel strong, safe, and secure in their bodies. In this podcast, I'll share expert advice, facts, amazing guests, stories, compassion, and hope to help you meet your body in all seasons of life. I just got off our podcast recording today with our special guest, Rebekah Rotstein, and I could have kept talking to her for hours. Many of you are going to recognize Rebekah and her name and her business, Buff Bones, because I have personally sent so many of you to Rebekah when it comes to learning about how to exercise with osteoporosis. And that is what we are discussing today, considering we are in the midst of our muscle strength program in my unlimited community. And I get so many questions from so many of you about how to exercise with osteoporosis. I knew Rebekah was who I wanted to bring on to talk to you about all of the things. So we discuss osteoporosis versus osteopenia, how to help improve your bone health and bone density, how and when you should get tested, and how exactly to exercise to best help your bones. So let me tell you a little bit more about Rebekah. Rebekah Rotstein is the founder of the Buff Bones exercise method for bone and joint health with virtual coaching, online programming, and live classes with trained instructors in more than 30 countries. She's taught courses at locations like Johns Hopkins Rehabilitation Network and oversees a free public education webinar series with UCLA Health as the health sponsor. Rebekah is an industry leader for movement education, bone health, and Pilates for more than 20 years, with a background in dance and sports medicine. She has contributed to several books, including The Myths of Menopause, and serves on committees including the Bone Health and Osteoporosis Foundation and the Medical Advisory Committee of the National Menopause Foundation. Rebekah also tells you in this episode her own story of being diagnosed with osteoporosis at the age of 28. And now, more than 20 years later, she has dedicated her profession to helping other women with osteoporosis live empowered and strong lives. I am absolutely thrilled to bring you this conversation today with Rebekah Rotstein. Hi, everybody. Thank you so much for being here for another episode of Meet Your Body. And I kid you not that I emailed Rebekah last week and said, I desperately need you on the podcast. It has been on my to-do list for a year to reach out to Rebekah, and I finally did. And she was so gracious to do this last minute because I know so many of you are doing our muscle strength program this month. And I want you to have all your questions answered about how to lift and move safely with osteoporosis. And this is the person for you. If you've ever worked with me individually, you know I send you right to Rebekah for all of your osteoporosis questions. So Rebekah, thank you so much for being here and doing this so last minute for me.
Absolutely. It's good to be here with you.
So tell everyone just introductions, whatever you want everyone to know about your story as a professional, personally, and what really led you into wanting to work with the osteoporosis population.
Well, I initially didn't want to. It kind of chose me in that I was diagnosed with osteoporosis when I was 28. Wow. So I'm just about to turn 50 now. So we're talking, it's been a while. And it came as a really big shock. And I was already an exercise professional at the time. And even with all the resources that I had at my disposal, it was still a shock. And it was still overwhelming and scary. And with my background initially as a dancer, I had a really strong identity with my body as part of my identity, I should say. And so my world really just turned upside down. And so I have a very, I would say, I have a very clear understanding of what many people are going through when they're surprised and they're dismayed at a diagnosis of osteoporosis. And especially when you don't identify as somebody that is the classic stereotype of frail, which is what you're often told. So it's really jarring, and it's a big dissonance between how you think of yourself or previously thought of yourself and now are often led to believe how you are. And so overcoming that is a big deal. It's something that is a process but is very doable.
Yes. And I absolutely love that, because you're right. We really don't honor that and recognize that very often, that dissonance between, getting that diagnosis specifically for osteoporosis. And you're right with that visual of frailty. And also, I better just stop moving. I just can't do anything anymore. And you being 28, that obviously wasn't an option. Tell us how that diagnosis came about for you? I mean, obviously, you're not getting DEXA scans when you're 28, I'm guessing. So, how did that diagnosis happen?
Well, actually, I did get a DEXA scan, and I did because my background had initially been in sports medicine, and I was going to go to physical therapy school actually after college, and then decided against it. But I had been working as an athletic trainer, so physical therapy for athletes throughout my whole college career after I'd quit dancing. And so, with that, and then with additional coursework I'd taken, and I worked in teaching special populations curriculum for exercise pros, Pilates teachers, and such. I had taken extra coursework and discovered at the time that I didn't even realize how you can build this majority of your bone density by the time you're finished with your teenage years. So the statistics change, but it's about 85 to 90% by the time you're, close to 20 years old. And so I knew my own background, having been amenorrheic, meaning I stopped menstruating, as is really common with top performing athletes and dancers when they're younger, especially. I knew that I was susceptible, and it runs in my family, and I'm very tiny. So I had a couple strikes against me. So I thought, let me just get a baseline right now. And it is, looking back, I'm kind of shocked that the doctor even allowed it, because it's so hard for women to get even a baseline when they're 50. But the doctor obliged, and so I just thought I'd have an idea for later. And it came back as, oh, you have osteoporosis, you have the bones of an 80-year-old, and here's a medication to take. And so I started diving in, doing some research, and realized also medications at that point weren't tested on childbearing age women. I was very young. I wanted to also see what else is going on here. So I did some sleuthing, worked with a number of professionals, including an endocrinologist. But I was able to get a DEXA. And so I was actually very fortunate, because more often than not, it's a fracture that is the telltale event or sign. You're not able to just get a screening. So this has also been something that I've been working on just as advocacy for people in general, to try and be able to obtain DEXAs, not necessarily in their 20s, but around the time of the menopause transition.
And I love that. It's a perfect transition. I wanted to talk about this, so let's get right into it. And you can tell us a little more. My understanding, as I've learned more in the past year, is that absolutely by the time most of us get our DEXA scans at what ages 60 or 65, it is, I don't want to say too late, because I do not believe it's ever too late, but we have lost a good portion of bone density at that point. Like, we need to have that information in our late 30s or 40s, or like around 50 at the latest, so that we can put in preventative measures. Tell us about that. Like, as you said, you're an advocate for this. what does insurance say right now, or what's kind of the typical recommendation for getting that DEXA scan? I guess tell us what is a DEXA scan in case anyone's listening and doesn't know. And then what are your general thoughts about when women should have that baseline measurement?
Sure. So first of all, a DEXA is sometimes you'll see it DEXA, sometimes you'll see it DXA. It stands for dual energy X-ray absorptiometry, which is a mouthful. And essentially, it is a bone density test. It's a screening, but it's also a diagnostic tool for osteoporosis, or if you have low bone mass en route to that. And it's very simple. It is very low radiation exposure, and you will get your results very soon thereafter. Now, the recommendation in the United States, and coverage, I should say, is for women 65 and older. But, I started looking at this 20 years ago thinking, wait, this doesn't make sense, because if we know that you can lose up to 20% of your bone mass in the first 5 to 7 years after menopause, that's the big window. And if the average age of menopause in the United States is around 52, 65, we're talking 13 years usually post-menopause at this point. So we've at this point had a huge decline. And then, we also have seen, and it's coming out more, that it's not even just post-menopause, that there's a period of rapid bone loss that occurs. Usually it can be up to around 3 years long. That's before the final menstrual period. So in perimenopause, that about 1 to 3 years before the last menstrual period is when we actually have a big decline as well. So, it's not even that it's an older thing. So going back to what is the screening? So the screening is giving you a measurement, and it is measured in grams per centimeter squared of a given area. It's looking at least 2 sites at the spine and the hip, and sometimes it also looks at the wrist. Mm-hmm. And I believe, is very important for people to have as a baseline sooner than in a triage scenario. So the way the medical system has worked traditionally here is that we're looking at who is at most risk or greatest risk. And I started doing a deep dive many years ago into this. And so 2 decades later, I'm discovering some big changes, which are really exciting, that people are finally starting to think about this as a preventative action. But I used to say that bone health isn't sexy and it's never going to be. And I was wrong. Like, it's becoming sexy, which is shocking to me and wonderful. But people are finally interested, where I felt like I was like banging on doors for so long to get people to listen. And what's interesting about this, though, is that if we can screen sooner, we have an opportunity to intervene. So rather than just thinking of osteoporosis as once somebody has fractured, or who is at greatest risk and what's the greatest healthcare toll financially, as well as just in terms of care, it's seniors. And the greatest risk of osteoporosis are fractures, and those who are at greatest risk are seniors, because the biggest risk factors are a previous fracture, but B, also age. So as you age, the algorithm for fracture risk increases basically exponentially. So we're really most concerned, and the medical system is most concerned about seniors and hip fractures, because there is a direct correlation to mortality and death that can happen, not to mention total loss of independence. But we have a really great opportunity to prevent that at our midlife point. So that's something that I've been involved in for a while. And even earlier this year was advocating on Capitol Hill with Congress, in the congressional offices, as one of the things to try and lower the screening age. To advocate this, to bring it even toward a bill, which would be nice, because it's too late. Okay, it's never too late, as you said, but it really is too late to think about it at this point. We should be thinking about it sooner. We should have it on our minds, and we're seeing that now. So while it's never too late to take action, it really isn't optimal to be considering a major factor in your health and longevity by the time you've already lost a significant amount of your bone mass.
Yes.
So this has been a passion of mine for a while. And also, we did this, I should mention, with the Society for Women's Health Research. I'm part of the Bone Health Working Group, and we put together recommendations that were published, I think, 3 years ago now, published in the Journal of Women's Health. And that's one of the things we advocated for, is lowering the baseline screening
Yeah,
age.
that's amazing. And hopefully that will come. And we also know in healthcare, things move very slowly. So, and government, you combine healthcare and government together and we're talking slow. But just the awareness out there is so important. So for women, and you can tell me if my understanding is correct, because I'm 47, everybody, I need to go out and advocate. And so this fall, seeing my doctors, I'm going to get a DEXA scan. So this is something you can also pay for on your own. You don't necessarily, is that correct? Like you
Yes.
can go and schedule a DEXA if you have the means and you have the financial ability to do it. You can do that on your own. Is that correct?
It is, and it's surprisingly less expensive than most people think. We're not talking in the same cost frame as like an MRI or a CT scan or other types of imaging. In the United States, you can get a DEXA for $100 or less. But the thing that I do want to clarify is there's a difference between going to a full body. There's a number of facilities that have been popping up of full body DEXAs, body composition. That is not what you really want to be measuring your bone density. You want to go to a medical facility for this, the same type of facility that you would go and get your mammogram. Most of the time, it's the exact same facility. So they're going to run a DEXA there as well. When you're going and getting these full body DEXAs, it's not comparative, it's not the same, and you're not getting specifics on the site specific areas that a physician is going to be looking at and that is really needed to be monitoring throughout time.
Yep. No, that's great to know. And when you do get results back, wherever you are on the phase of getting your scan, tell us overview of osteopenia versus osteoporosis.
So, osteoporosis is the actual diagnosis, which is of loss of bone mass as well as changes to the architecture, the structure of the bone. And that is important because I still see a pretty old definition, I guess I would call it, of just it's low bone mass. It's not just low bone mass because it's the changes to the bone quality. And this is something that I find really interesting because when I started my deep dive like 20 years ago, I started seeing stuff about bone quality in research, yet there was nothing in the public sphere about this. And now you're hearing more about it finally. But that is an important distinction. And in fact, we have a webinar coming up for the public that is with one of the pioneering leaders in bone quality. And this is important because it's called the trabecular bone score. And this is a software that is used in conjunction with the DEXA that can give you an estimate of your bone quality in addition to just the density. So this is important because density is the amount of bone that's in there. The density is, if you think of it as the mineralization, but then the quality has other aspects to it. And so you can actually have low bone density that may classify you as osteoporosis. But when you look at the quality, it's actually pretty good. The architecture is pretty intact. And so that's also an important indicator of fracture risk. And it could also go the opposite, though. You might see that your bone density is higher than, say, osteoporosis, but the quality shows as poor.
Yeah.
So I skipped over one thing that you were asking, which is, so this is osteoporosis. And it's that combination of loss of bone mass as well as changes in the architecture that can make it more susceptible to fracture. And I say can because it doesn't mean that you're going to fracture.
Well, that's a good
That's the
point.
important thing. You can live a very long life with osteoporosis and never experience a single fracture. So it's very different from, say, cancer or certain other pathologies. Now, osteopenia is considered the precursor to osteoporosis. And there's been a lot of debate as to what the use of the term, the creation of the term, the meaning behind the term. But essentially, it means that you have low bone mass that is not at the level of osteoporosis, but is less than what is considered normal.
So like just a little warning, a little, hey, let's pay attention to this.
Yes.
And one of the most common questions I get, can I reverse osteopenia and can I reverse osteoporosis?
So the term reverse has
Mhm.
become very much a marketing term. In the medical community, this is not something that is talked about with my medical colleagues for good reason. And it is that it's considered that osteoporosis is lifelong management, just like diabetes. You
Mhm.
don't say, "Oh, great," or heart disease, great. I'm outside of the grave concern area, so I'm good. I can just move on with my life. No, you manage this for the rest of your life. So, you can appreciate this from a healthcare perspective.
Mhm.
The term of reversal, I don't know what it really means. I'll be honest. Can you reverse the trajectory of your bone loss? Definitely. You absolutely can. You can mitigate the bone loss, and it's even possible to increase bone mass. So, does that take you outside of the classification of osteoporosis? Yes. But what does the reversal mean? So, I'm always a little bit questioning to people when they ask that. What is it you're trying to achieve? You're really trying to avoid fracture. That's really what you're asking about. Because again, you do want to be outside of the classification of osteoporosis, sure. But you also really are saying, I just don't want to fracture, because
Yeah.
that's the biggest end goal that we should really focus on.
Yes, absolutely. And taking that, lead us into let's discuss exercise. And I know that's such a large topic, so we'll kind of try to bring it back in. But first off, um, let's go for weightlifting because it's what we all hear. It's what the research tells us. Yes, we need to be lifting weights. I think everyone listening knows that. Let's go a little deeper in what that looks like with someone who has been diagnosed with osteoporosis, because I know there's so much fear around how to move, what they find online, what Dr. Google tells them, what doctors tell them. Tell us how you approach exercise with clients with osteoporosis.
So it's interesting when we talk about the research that you see a lot of extrapolation of research. And part of that is not intentional. It's that people are not always realizing that it's different when the subjects have osteoporosis or low bone density than healthy individuals, just as it is different if they're postmenopausal or not. There's a lot of nuance that often just gets totally overlooked. So, when we're looking at what exercise to do, so there are three different things that are really the most formative elements, two of which are related to bone density. So the two that are related to bone density have to do with strength training and with impact training. The third part, which is balance training, is not related to bone density, but is related to fall prevention and fracture prevention. So it's like this interesting picture of all of it. Now, in terms of what kind of strength training and resistance training, it does need to be weight bearing, or it should be weight bearing as much as possible. And we want to try and get the axial loading. So when you're doing compound movements, which is full body movements, you're gonna get a better bang for your buck usually than small isolated movements. The intensity matters. Now, despite what you hear, we don't know for sure that it has to be high intensity over moderate intensity. Again, a lot of extrapolation of things. Does it have to be heavy lifting? Not necessarily. will that have better results in certain lifts? Not everything is going to be heavy lifting. Than moderate, possibly. We don't have enough data to make a lot of the claims that are being made. And there hasn't been a head-to-head trial looking at moderate to heavy, despite, again, what people say. So I think you have to take a lot of this stuff with a grain of salt. And when we're talking about intensity, yes, it does matter that it's more than low intensity. That the greater the strains seem to have better osteogenic effects, meaning greater bone building effects. But there's a lot we still don't know. So the idea is you want to be going to as much effort as possible where you have almost nothing left in the tank. You have like 1 or 2 reps remaining. We have seen that yoga and Pilates, while beneficial for so many different things, are not the answer for bone density. And at the same time, that doesn't mean to throw them out. There's so many different benefits that they provide, especially for neuromuscular control, a lot with sensory motor integration. There's so much for balance, fall prevention, what we call self-efficacy, your confidence in your belief in your ability to perform tasks. But when it comes to bone density, they don't seem to be enough. But at the same time, people like to get into an either or, a black and white mentality, and that's not the answer. Back in, about 11 years ago, an important paper was published which showed what really needs to be done for osteoporosis when it comes to exercise is a multimodal approach. So that's great. It means that it's not one thing. But if you're looking at your hierarchy, yes, strength training is up there at the top when it comes to bone density. And let's see, what else can I tell you about that you'd like to know?
Just from a basic standpoint, if the research says how many times a week and how long, just because I know those questions come up, people want, like you said, they want a checklist. We want a recipe to follow, completely understandable. 2 times a week, 3 times a week, what do you recommend for people when it comes to lifting?
So the guidelines are that you need at least 2 times a week. I know that some people want to do 4 times a week. The biggest thing that has been shown in adherence and compliance with exercise is that people who do it are going to get results. So in other words, I think people, they over strive, if that's even a word. You think, oh, I got to do so much. I like to keep it simpler for people, so that if you just have 2 days a week of strength training, and then you have other days that, say, you're doing a Pilates that you like, or you're doing a safe yoga class, or you've got Tai Chi, you like taking a Zumba class, or you love hiking, or you do HIIT training, you go for a run. There's so many different things that can be done. And of course, impact training, I'm counting in here as well. But it has to be achievable. And I think that's where people get carried away. And if you also are incorporating things that you really enjoy, maybe you love doing strength training, and that's great. If you don't like it, though, and you know that you're just doing it because you're doing it for your bones, and that was definitely me 20 years ago. I guess 21 years ago, I started working with a trainer right after my diagnosis. And did I like it? No, but I did it because I knew it was helping me. And I also did all the other things that I really enjoyed. So I think you have to have the enjoyment factor in there. So the guidelines show you, though, for osteoporosis, at least 2 times a week with strength training. Now, so that's for frequency. When we talk about duration, well, you can't ever put an exact time on it because it depends on what you're doing. So what is the intensity you're at? That's going to change things. What is the style? Are you doing supersets, which might change the duration? Are you, what is your periodization like, and even what's your recovery within an exercise? So all of that is very variable. So there is no aspect of duration that is in guidelines, because you can't. It's very different from a cardiovascular or cardiorespiratory fitness standpoint, where you say, I want you to be doing this for 30 minutes
Yeah.
straight.
Yeah.
So that does differ
Yeah.
based on what each individual is doing.
Yes. And talk us through someone who has a regular weightlifting practice or strength training, we'll say, 2 or 3 days a week, 20 minutes, they're super comfortable, they've been active, they go in, get a DEXA, and they suddenly are told they have osteoporosis. And right, the fear, like everything comes crashing down. Oh my gosh, I have to stop everything I'm doing. But yesterday they were doing it and they were fine. The only thing that has changed is an official diagnosis. Do you change what they're doing? Do you adjust some of the positions and the overload and the flexion? Do you not? How do you coach someone in that position?
So I'm glad you bring that up, because this has been my experience for many, many years now, that people come in and they're absolutely terrified. They're just going to crumble. And the only difference between today and a week ago is the diagnosis. Your body didn't change that much within 24 hours, even. So it's very much a mental hurdle to address. But separately from that, in terms of programming, I absolutely recommend that you have some kind of assessment with somebody, whether it is a physical therapist or whether it is an exercise specialist who's trained in osteoporosis. This It is important to because I should say it's important to have some understanding of what your program is going to be. And it really should be personalized. And that's what all the guidelines have been pointing toward, that it's extremely individual. And especially because, what is your fracture risk? Well, it's interesting. The major fracture risk tool doesn't take into account anything of physical function or capacity. So there is a shortcoming there, but I do want to know, what is, somebody comes to me, I want to know what's their DEXA, what's the T score, which is, I should have mentioned before, when you get a bone density test done, you are, not only do you have the actual measurement, but what is given to you is an actual score, especially after, around the time of menopause, perimenopause, or afterwards. You're given a specific score, and that score is how you know where you fall in the scale. And that's what is classified as normal, low bone density, or osteoporosis. So I would like to know what that score is, because I do see some people with very, very low scores, and that could potentially put them at risk with certain things. I also want to know what's their medical history, because if we're dealing with somebody who's been on certain cancer treatments, for instance, I know that it's possibly not just low bone mass because it's a tiny person. They've had bone quality implications because of, say, radiation from, say, breast cancer, which is possibly going to implicate the bone quality of the spine and the ribs. So there's a number of different things. I also want to know, like, were they on long-term corticosteroid use, right? They were on prednisone because they have Crohn's disease. Well, that also means that it's not just a density issue.
Yeah.
There's possibly other things going on with the quality beyond what we even get from that quality score that I mentioned. So I want to know a lot of these things. And then also there's just physical assessment, right? Any kind of health risk assessment, but also a questionnaire, and then looking at them to identify, all right, where are your deficits? What are your shortcomings? What can we help you with? So, because it could be that somebody's been doing strength training, but I see this all the time. People come and say, when they come to our program, oh, I don't understand. I've been doing strength training for a long time and I have osteoporosis. And it's the way that they're doing it, right? They may not have been doing it enough. They're often not tracking what they're doing. They're often not progressing what they're doing. They're often not periodizing. Like, there's a lot more of the science to it than just lifting up a weight
Yeah.
to determine how effective it is.
Yeah.
And then that also plays out not just in how effective is it, but also how much would you possibly putting yourself at risk. Now, it's not considered that it's risky to strength train. However, when you get into heavier loads, you need to make sure that you have good form. And I have had a number of people that have come to us who have fractured by lifting weights because they didn't know what they were doing or they were poorly guided. So I think it would be erroneous to dismiss that there is any risk.
Yeah.
Now, that said, you should not be scared of exercising, but you should get the guidance that is appropriate.
Yes. And I love this answer so much. I want to dive in more to it. Before I do, are there any, like what you see online, right? Like no crunches, no loading, flexion with rotation, these things that everyone can find the guidance on. Is there accuracy to those? Are there any general movements that you say, okay, yep, you were diagnosed, you need to stay away from those? Or are all of them nuanced and individual?
So it's interesting what has really changed in 20 years is that's a major thing that has changed. I mean, I could count on, just keep going off on how many changes have been happening. But one of them is that it's not a blanket statement. It's not, okay, you have osteoporosis, so you can't flex your spine. And the guidelines have been intentionally vague because they want to move away from fear-based suggestions and recommendations, which I think were probably more prevalent before. So as a result, it's you may want to modify the following if you have osteoporosis. And so it's not a blatant you have to. And this is where it depends on the individual. Again, taking all these different factors into account, and especially if there's been a previous fracture of the spine, that plays a big role as well. But and it's specifically where things have moved is into exercises or movements that are loaded or that are weighted. So that's like a Pilates rollover or a yoga plow pose. You could think of as that example. Things that are repetitive that you keep doing, a series of roll ups. Perhaps, again, you may want to, it's not to say that it's completely for everybody. Things that are rapid or forceful.
Okay.
Things that go to the end range, things that are sustained, that you're just hanging out in a pose, for instance, where for instance, you're at that end range, you're in that loaded position. And this is also, it's a combination as well of any of these. So it can be the flexion, it can be the twisting. So again, we had somebody who said to us recently, well, that's so vague. I'm like, I know, I think they're doing it on purpose
Yeah.
because they don't want to be too definitive because we don't know for sure. However, I think this is where it gets tricky and this is where experience comes into play. When you've been working in the field for a few years, you can say, oh, well, this is the way it is. The more decades you have of experience and exposure, the more you've seen. And that's why I think one of my original mentors in this was exceptionally conservative because she saw the worst of the worst. And so, I think that's what we're seeing is a bit of a polarization right now. Those who are saying, you don't have to worry about anything. Like, there are no contraindications. And it's true, there aren't direct contraindications. And on the other side, you have those who say, don't lift more than 20 pounds, which again has also been disproven. So there's something in the middle.
Yeah.
But I do understand those who are more conservative because, the more you've seen, like I can't tell you how many fracture clients I've seen over the years. And it's not good. And you want to avoid it at all costs. That said, if you have had a fracture, it doesn't mean your life's over. There's still so many things that can be done, and you move onward, and you can still lift weights and you can do a lot of things. But there's caution and care that needs to be taken. And so I think it's a balance between being totally cavalier and being hyper vigilant.
Yes.
But that's where things have moved, that it's not a cut and dry, yes, you can or can't. When people come to us, this is where we do an assessment, we do an intake, and we want to get as much information and guide them as safely as possible, while also encouraging them as much as possible and strengthening them as much as we can.
And I think that just applies to so many areas in our lives. I mean, I can say with pelvic floor and prolapse, exact same thing. You get diagnosed and it's suddenly so fearful. Don't ever, and you have doctors even telling you, don't ever squat again. You can't ever do this again. Okay, that's not realistic or helpful. So just completely stop moving puts me at risk of so many other things. But you're right, I can't go do whatever I want, or my pelvic floor will absolutely bottom out. Like that is just the fact of it. But what I find is we have to be willing to take the time to learn what we can do. And I absolutely acknowledge it takes time, it takes effort. It feels like a job sometimes to figure out what you can do and what you can't do. You have to seek out professionals who will encourage movement. So, if you are getting that new diagnosis, take a breath, take a moment. You can let yourself even be upset about it, but don't let yourself stay in that place. Like move forward, seeing people who do encourage movement and who will help you get to know what you can do, because there is so much. And like Rebekah said, it's not everything maybe, but that's okay, because you focus on what you can do and you modify and there's nuance. And I just want to say, as a physical therapist of 25 years, not all physical therapists know this. Okay. Like we all have different specialties. So if you are going to see someone, make sure it's someone who knows osteoporosis, because I guarantee you there are some PTs out there, not anything bad. It's just, there's a lot going on in the medical world. There's a lot of PTs who will go back to that. No crunches, no loading, don't ever lift weights. Like they will actually keep you in that fear spot. So make sure you see someone who's up to date on current research about osteoporosis. I think that's really important.
Yeah, definitely. And the idea of taking the time is also critical, to allow yourself the grieving process, because it is a grieving that can happen. And then again, as you said, take the time to learn and seek out those who can support and guide you, because that's going to be so critical in your, whether it's recovery or your next path, that will really make a difference for you in how you move forward.
Yeah. And for all of you listening, many of you probably know because I've sent you there before, I do send you to Rebekah and to Buff Bones, her business, her platform for osteoporosis and for that individual assessment. So if you are someone either newly diagnosed or you were diagnosed 10 years ago and you just aren't sure what you need to be doing, maybe you're doing your own workouts, you feel good, you're an unlimited member even, but you want just that individual nuanced of, is it okay I'm doing this? What can I do next? Rebekah is a great resource. So tell everyone kind of what you do. Tell us about Buff Bones and where people can find you.
Well, thank you, first of all. So with Buff Bones, you can find us online at buff-bones.com. You can also find us on Instagram at @gotbuffbones, also on Facebook. And we've trained instructors as well. And our virtual coaching program is the most comprehensive approach, though, for that truly personalized aspect, to get an individualized plan of what you need to get the education side of what you need to get the support, the coaching, and of course the exercise itself.
Mm-hmm. And some of you out there, and you can go to Buff Bones to see, but there are practitioners absolutely trained in this through Rebekah and through Buff Bones. And so you might have someone near you. If not, you can do it all online. But if that is something that interests you, there are practitioners all around the world. Is that right? Who are trained in your system and your training?
Yes, and what we've done a lot of is, so we started training exercise professionals in 2011, and there's different levels of it as well. So you have some people who have a training in the foundation element of, especially the body organization side of things. So to essentially prepare you for the lifting and the loading, and then we have others who are trained in that as well. So it's a variety. And then what we end up doing in our coaching program is making it, though, specific to the individual, along with the education side, which is part of what people get very confused about. Because, like I said, even with the guidelines have changed on exercise. They're actually recommendations, even on medication, have changed dramatically, and came out in our big annual conference with the Bone Health and Osteoporosis Foundation this year, that are not in guidelines yet, but I think probably will be in the future. And even some of the guidelines on medication were updated in 2020, and yet I still come across people very frequently whose physicians are telling them things that are actually not even according to what is the latest. So I think we try to provide people with a really comprehensive direction of what to do, because it's very confusing. It's very scary. And, I experienced it myself
Yeah.
at the time. And so to try and have that support that you need with those that you can trust, that are coming from a very balanced place and are working directly with physicians, have a lot of experience, I think has been something that has drawn a lot of people to us,
Yes.
because it's only becoming more confusing, to be honest, now
Yeah.
that there's more and more information. And I think it's great that, bone health is becoming very popular. I think it's terrific.
Mhm.
There always is a downside, though, of misinformation that can come out at the same time.
Which leads us to one more question I have to ask. We have to discuss weighted vests, Rebekah. Those of you who follow me, you know my thoughts on them. I have videos out about them. I Let's just answer the question. Do weighted vests help with bone health and bone density?
So it's funny. I want to say it was the end of last year. We did an Instagram post on weighted vests to clarify things, because we're hearing some rumblings. Couple months later, everybody's talking about them, everybody's posting about it, and it's fascinating. And I was contacted by the New York Times this summer for a piece about this, to speak about it. And so here's the deal: we don't have data to really show and make claims that weighted vests will help your bone density. What we do know from the studies is that the studies are very small, often not randomized, often not even separating exercise from the vest. So is it the vest that helped, or is it the exercise that helps? So, I think the popularity in them has been perhaps because it seems like a quick fix or hack that everybody wants, like, what's the quick hack? What can I do? And so, sure, you could stack one more thing. You're already doing all the things around your house. Why not just add more load on? I can see the appeal, but what ends up happening is, again, we become very reductionist. So it's like, oh, well, this is the thing to do. Well, in reality, what has really been shown to help bone density, whether it's mitigating and stopping loss or potentially even increasing it
Mhm.
after menopause and with osteoporosis, which again are different than not even including those two parts in your statement, is resistance training.
Lifting weights.
So we know that that can help. Um, and to some degree, impact training. Now, again, impact training is even a little different, because when it's with osteoporosis, it doesn't have as high of certainty, in fact. So it's different for premenopausal than it is postmenopausal with impact. And people don't usually get into that little detail. But why are we not sticking with the things that we know can be so helpful, as opposed to just walking with more weight? So that's my take on it. And because I started seeing clients in the mid O's that were using weighted vests, and I started seeing a lot of problems that they started incurring. So if you just start adding weight onto a body that is not well organized, that already is prone to injury, what ends up happening, what we've seen, myself and my team have seen, is we see an exacerbation of the underlying issues. So, and that's not even mentioning, say you've had a past fracture, for instance. So I see a number of potential challenges, to be honest, with the vest. Now, if you like the vest, and I have also seen clients who love their vest, they don't do it at the expense of the rest of their programming, but they like it in addition to. If you've had good results with it in terms of feeling good with it and you enjoy it, then great. It's not to tell you to stop using it, but don't try and use it at the exclusion of something else. And I think the other thing that's interesting is some people I've heard say, well, it's great for feedback. That's a lot of feedback. For sensory feedback, you're putting a lot of pressure on your body. So I think there's other ways, if that's your goal, I think there's other ways you can achieve that. But if you like the vest, okay, but just be careful about the claims that you're hearing with it. And now what I'm seeing is actually a lot of people debunking those claims, sort of like we were doing last year. I think that's good to at least be clarifying what the research shows and what it doesn't. Now, what's interesting is there's a study with obesity, and that's a totally different population, because what they're looking at is, well, to combat the bone density loss that could occur with weight loss, can we use a vest for that? That's very, very different than for the average population to say, oh, is it going to help your bone density?
Yes. So, moral of the story, lift your weights. Keep lifting your weights. Add some impact. Do your Pilates and your balance training. And then if you really want to add a vest for fun and you're healthy and it feels good, add it on a few walks. But to help your bone density, lift your weights. So.
Yeah, and I think, even before starting with the vest, it can be also helpful to check in with a professional about, hey, what do you think? Is this appropriate for me or not? Because a majority of the time, if somebody says that to me, I'd be like, no, actually, I don't think it is, because I'm looking at all these interesting deviations, compensations that I think would be better to address before you just add on load without knowing how you can manage it yourself.
Yes. Thank you. Thank you. There's your weighted vest question, everybody, because I knew you were going to ask. Thank you so much, Rebekah. I will have the links, everybody, below on where you can find Rebekah and Buff Bones and how you can get your own virtual consult going with her. And we will have all of that. And thank you all for being here. And thanks, Rebekah, just for all the advocacy that you do. We appreciate it.
Thanks, Jessica. And thanks for having me.
Yep. Talk to you soon.
Bye.
Thanks so much for listening today. I would love it if you could take a moment to subscribe, rate, and review this podcast. It means a lot to us and it helps our content get out to more women who need it. You can find more of my resources at my website, jessicavallant.com, or find me on YouTube at Jessica Vallant and Instagram at Jessica S. Vallant.